Hepatic veins do not. And why is that? Well, it's a matter of contrast. The hepatic veins have imperceptible margins. They actually have walls, but we just don't see them. If we look at what they look like by configuration, they're more vertically oriented. They enlarge towards the inferior vena cava, and they actually have sort of an umbrella configuration where the spokes of the umbrella come together superiorly and the rest of the spokes drop down throughout the liver. Now these veins are found between lobes and segments, so we use them as anatomic dividers, and they carry blood flow out of the liver. They do not have any other adjacent little structures, therefore we do not perceive their walls. Here's an umbrella, just for your imagination. You can see that the spokes of the umbrella come together at the top, which is here. So if we take a slice through the very superior portions of the liver, we can see longitudinal orientation of the hepatic veins. Now, as the veins drop down and we take a transverse section lower, these veins will be cut and look as like circles. So here is the middle hepatic vein, and here is the right hepatic vein, showing us lower in the liver as a cross-sectional configuration, cross-section, which we would be doing through the spokes of the umbrella. Now, having said that, we always find exceptions to the rule. Now, I just told you that portal veins have bright walls, and now all of a sudden I'm showing you a picture of a portal vein that does not have bright walls. Some portal veins may not show echogenic walls because they become parallel with the beam. Parallel is the worst angle for B-scan. So we're losing resolution, and we simply lose resolution of this portal vein wall. Here, on the other hand, are hepatic veins. Now, I just told you that hepatic veins do not have bright walls, and all of a sudden I'm showing you a big hepatic vein with bright walls. Well, it is true that some hepatic veins may show echogenic walls. That's because they're large veins and they have thick walls, so they do have reflectivity, but also in this case, this vein is completely perpendicular to the sound beam, and that's the best angle for B scanning, therefore we see the hepatic vein wall. So, two exceptions to the rule explained by angles. So we have some now a little bit of insight into the anatomic landmarks on transverse scans of the liver, and let's look at these. In high portions in the upper parts of the liver, we see large hepatic veins coming together into the inferior vena cava. In the mid portions of the liver, we see the portal veins kind of horizontally situated, the left being a little higher than the right, but nonetheless with the bright walls. That we know now that we're in the middle of the liver. If we look at transverse lower sections of the liver, we don't see any big veins. We see an echogenic line here. This would be where the falciform ligament comes in, and the umbilical fissure, the fissure for ligamentum teres, and that will mark the lower parts of the liver for us. So we'll know if we're high, mid, or low in the liver. Now, since I mentioned ligamentum teres, let's talk about that. Ligamentum teres means round ligament. We have different round ligaments in our body, but this is the round ligament in the liver, which is the obliterated fetal remnant of the umbilical vein. So the fetal umbilical vein, once the fetus is born, there's no need for that vein, so the vein clamps down and becomes almost like a thick fibrous kind of cord located within a fissure, within the fissure for ligamentum teres. So the fissure has a little fat in it. That's what gives us bright reflectivity. So somewhere in here is the collapsed, obliterated ligamentum teres, surrounded by echogenic fat. This is a transverse section of the left lobe, and that becomes a divider of the left lobe into medial and lateral segments on a transverse scan. Also notice that there's some shadowing behind this. And the reason that it shadows is not because it's calcified, and this should not be mistaken for a calcified mass, but it's because the ultrasound beam strikes this at 90 degrees, which is directly striking this fibrous cord, and that shadows behind it. As soon as you change the angle a little bit, that shadowing will disappear. If it was truly calcified, there would be shadowing no matter what angle you come from. The fetal umbilical vein came into the umbilical segment of the left portal vein. We can see this when we cut the liver sagittally. At this precise level, we are now taking a sagittal image, and we can see the brightness of the fat surrounding the ligamentum teres within this umbilical fissure, and notice that it goes directly into the umbilical segment of the left portal vein. So that's where the fetal umbilical vein enters the portal system. This vein may recanalize in portal hypertension, and once again, it is a divider of the left lobe. So while I mention fetal remnants, I'll mention the ligamentum venosum. Ligamentum venosum is the obliterated fetal remnant of the ductus venosus. The ductus venosus carried blood out of the liver. In the fetal circulation, blood entered the liver, but there was no reason to stay in the liver, so there's a ductus venosus that right away carries the blood out towards the inferior vena cava and towards the fetal heart. That ductus collapses once the fetus is born, and it lies within the fissure for ligamentum venosum. Now, here on a sagittal section, that fissure appears to be a bright line, which is located between the caudate lobe and the left lobe of the liver. Behind the caudate lobe is the inferior vena cava. Okay? When we turn 90 degrees and do a transverse section, the fissure appears here again as a bright echogenic line. Somewhere in here, we don't know where, is the collapsed ductus venosus, probably closer here to the umbilical segment of the portal vein. So it would have come out, and on higher sections, it will enter the inferior vena cava. Notice that that fissure is a broad plane. It's a line on transverse, it's a line on sagittal, so it is not a linear kind of fissure, but it's rather fairly broad. And that is our divider for caudate lobe from left lobe of the liver. This vein does not recanalize in adults. You don't see this vein ever again, except perhaps in the very small neonate that has umbilical vein catheters. You might see it, but once the child grows, this vein is obliterated and does not recanalize in portal hypertension.